that now. This is a good indication to talk about not pulling on the Velcro straps, because what you're going to do then is create skin breakdown and pain for the patient. The splints, whether they be rigid or soft, serve the purpose of the functional placement and holding of the hand. All that the straps do is merely hold it on. There's no reason for this type of pressure to be applied, just very gently, just to fit that patient's contour of his or her body. And then we can raise it up. Generally, this is a brand new splint. These would be all rounded off, so there's no sharp edges by the therapist. Often the rigid and the soft splints are labeled on days, off nights, on days, and for what hand they're for, as well as directions being put in the care plan for you. And in-servicing, lots of in-servicing by your therapist. One last word about splints, and probably one of the most important of all, is splint precautions. If there are any signs of redness, pain, swelling, or skin breakdown, the splint, whatever type it is, should be removed immediately. And the nurses or your therapy department should be contacted, and the splint should not be reapplied until they are contacted and the problem is solved, which often means that there'll be a refabrication or a changing of the splint, or maybe an entirely different splint may be required. So it's very important that you do thorough skin inspections, not only in the morning or in the evening when the splint is applied, but throughout the course of the day, removing the splints for hand washing and hygiene. It's very important that all materials are maintained in immaculate order and that all the skin is inspected thoroughly. Even perspiration, as I briefly mentioned before, can create a hot, damp, moist environment where pressure areas can start becoming broken down and very painful to the patient. Let's now turn our attention to palm guards and washcloth rolls. First, I'd like to say a word about washcloth rolls and tight, contracted hands. By contracted hands, I mean that tight fist that you'll frequently see patients in long-term care that they've developed over years. In fact, I've seen several where the nails have actually embedded into the skin. And as a result, nursing, by trying to help with this problem, and therapy too in the past, has used a washcloth in the palm of a patient's hand. But now it's felt the washcloth, because of its texture and the softness of the material, actually increased more contracture or tighter fisting to happen. So traditionally now palm guards are used. It's made out of a lamb's wool-like type of material. It's affixed with a Velcro strap. There is a hole in the side for the thumb, and it's usually very, very soft for the patient, and they find that it's very comforting. Again, it can be worn in the day or the night. My personal feeling is that if a patient has any functional use of their hand, even if it's just a small pinch, that any of the palm guards should be left off in the day so that the patient can actually use the little mobility they have in a functional way to help wash their face, maybe pick up washcloths, help with feeding. So frequently you'll see these just on at night if there's any use at all of the hand. I'm going to put this on now. And again, the strap would be rounded so that it could not cut the patient, and it would be shortened quite a bit. Palm guards can also be washed, even in a machine, with soap and water, warm and dried, so they can be sent down to your laundry department. Let's now proceed to cones. Cones have been used for many years in especially long-term care facilities. What should be remembered about a cone, and this one has a soft strap to hold it onto the back of the hand, is that the large end of the cone should always be placed where the little finger is. And that's traditionally how a patient that has some tighter fisting would utilize the cone in order to increase the size and dimension of the grip. When a patient starts developing contractures or fisting, it's very, very painful. Then when the hand is trying to be forced open to wash it, it's very, very painful. That's why a variety of splints, both soft and rigid, are used in therapy departments for the patients. We should talk a little bit about splint care on a rigid splint, which for our purposes today include the functional hand and the cone. They should be washed with warm, soft washcloth, warm water, and soap, not hot, because a lot of the materials these splints are made out of will melt if hot water is used. The straps should be kept dry. The stockinette, which I showed you initially, should be washed out every day, because even though you may not see food stains, there's perspiration that results, and these dry overnight or in the day if the patient has a wearing schedule as such. It'll dry very quickly. Everything must be kept clean. The wrist cock-up splints can be washed by hand in warm water, and these will dry within about a 12-hour period as well. Everything on your patients, everything we've even spoken of today, must be kept in immaculate order, as you would want for any of your own family. We're now going to look at a lower extremity orthosis called an ankle foot orthosis, or more commonly referred to as an AFO. An AFO is used on a patient frequently that has had a stroke again, that has no control over their ankle or their foot in any way. And the AFO gives them the support that they need in order to start standing balance and ambulation training. It's made out of a hard plastic type of material, and there's Velcro, again, closures. These can come in prefabricated from a company, or they can be fabricated by primarily a physical therapist. Before the AFO is even put on a patient's foot, the foot should be inspected to see if the AFO from the previous day has created any skin breakdowns, sore, or painful areas. How it's put on is first it's inserted into the patient's shoe. Then the back of the AFO, because of its smoothness, actually acts as a sort of a long-handled shoehorn, which greatly assists in putting it on a flaccid leg, which means a leg with no control. Then you can lift the patient's leg back, push down on the knee, and it goes right in.